Hi, a very good afternoon to everyone. I'm Dr. Go, Director of Institute for Clinical Research, the host for this webinar. As you know, from March 19 till now, we have organized 12 webinars, and we are very glad all of you and many of you have consistently come and visit and attend this webinar. While waiting for our beloved moderator, Dr. Chris, I would like to update you. This webinar is very special because it goes on to 6 social media platforms, and today there are about 28,000 people have viewed of more than 4.7 hours. Also, at any webinar, we have 1,900 people watching, either real time or after the session. And with the effort of the team, Dr. Chu Cheng Hun and all, we have also made into an eBook. So this milestone that we have achieved was never expected when we first started. So DG is very glad, and he actually praised us for the great work. And we are now, I think, we have started with Dr. Suresh as the first speaker to this webinar talking about clinical management at that time during the peak where a lot of things are unknown. And today we have Dr. Suresh back to tell us what the update about WHO has proposed and what the Ministry of Health Malaysia together with the ID physician have decided. So this is a preamble, and I see Dr. Suresh has gone to Sungai Buloh, and he will start the moderation. Dr. Christopher, you can take over from here. Dr. Chris, can you start? Tak dengar. Oh,
Still I mohon off the camera.
If not, I will let Faizah stop first.
They're coming on.
Okay, we shall start now. Dr. Chris, our moderator, he's our Deputy Director General of Research and Technical Support. Dr. Chris, the mic is yours. Cannot hear. We can't hear you. Maybe the mic is not on. Mohan? Huh? Shall we start with Faizah? Where's Mohan? I saw him walking out. So in the interest of time, we will get the technical issue overcome. And but
hello, can you hear us now?
Oh yes, we can hear you finally.
Okay, wonderful, great. Thanks, Pekwin. Sorry, we have to remind the Sungai Buloh people to pay their bills soon. Apologies. Thank you once again for joining us for this webinar this lunchtime. I'm pleased to be here in CRC, Sungai Buloh, obviously, in their new office. Looks very nice. And I think today's webinar is going to be interesting because we are looking at one very important aspect of our response to COVID-19 in our country. Clearly, we are concerned about mortality, and like any other country, that was something we focused very much on. I'm sure you would agree with me. Generally, I think we have done very well in the number of mortalities that we have by keeping it low. We are fortunate, and also we have to thank a lot of people working in the clinical side to make sure our patients get the best that we can have. Now, I'm sure all of us agree that there's still a lot of things uncertain about treatment and management. And in the last 4 months or 5 months, I think the treatment pendulum has shifted from one side to another, and you'll probably shift again going forward, as we know. Lately, in the press, in the media, in the last month or two, there's been some breakthrough landmark studies that have shown some good data on certain therapeutics. And sometimes it's difficult to keep track with them because these things change so fast. And especially now in the COVID-19, when we have a lot of preprints, a lot of publications that get published even before they get adequate peer review, sometimes it can actually confuse things a lot in the clinical setting. So we thought it would be a good time to get our expert, our local expert who has had the most experience looking after COVID-19 in our country, Dr. Suresh Kumar, who is the head of Department of Medicine and head of infectious diseases at Sungai Buloh Hospital, to share with us the current update about COVID-19 therapeutics. And he will look at not just only his experience here, but also looking at the current and new data that's flown in over the last couple of months. After which we will hear from Dr. Faizah Muhamad Zin, the prettier of the two speakers. Okay, Suresh is also quite pretty, but okay, maybe Faizah needs him a little bit. Faizah, of course, I'll introduce Faizah's credentials afterwards when Faizah's turn to speak. You might see her on the screen, all right? So without further ado, I'm going to ask to pass the mic to Suresh, and he will start his presentation now. Thank you, Suresh. All yours.
Thank you, Dr. Chris. I think as Chris has mentioned, we have had quite a few changes in COVID management, and we thought it's time for us to give an update on what we think currently the way COVID should be managed. Okay, this is the regular advice that we write. We put up the slides regarding this particular webinar, and with that I move on. So this is how we have been classifying COVIDs in Malaysia. This is our own way of classifying it. One is using category 1 is called asymptomatic, down to category 5, that is critically ill with multi-organ involvement. So many of the things that I talk about are related to this clinical categories. So you can group category 1 and 3 as mild, because they are the ones who do not require oxygen at all. And the category 4 and 5 are the ones who require supplemental oxygen or require ventilation. And so that's how we divide our clinical categories, right? Okay. So if you look at our own data, this is the data about, we have, I think along with NIH, our CRC, as well as the rest of the centers in the country, we have managed to put in about 3,600 patients into a database currently. And this is the spread of the cases that you can see. Majority of the cases are mild cases, as you can see here. And the number of, these are the severe cases, and these are the smaller in number, as you can see here. And the majority of the cases that we have seen in our country are mild. That means category 1, 2, and 3, and a small number that are severe. So to get you an idea of what proportion are mild and what proportion are severe in the country, right? Okay. So what do we do with mild disease, which means clinical category 1 and 2? The bottom row is sort of a picture of day of illness, right? This is a day of illness that we have. So what happens is they have a viral response phase, and then slowly the virus tapers off and they get better. And this virus response phase can be associated with no symptoms, mild symptoms, or a pneumonia which does not require oxygen. So that's the viral response phase. And when it comes to severe disease, category 4 or category 5, so we would like to see who, when, and how, right? So who gets these severe diseases? These are the risk factors for severe diseases: older age groups, pre-existing pulmonary disease, chronic kidney disease, diabetes with HbA1c 7.6 or above, history of hypertension, history of cardiovascular disease, obesity. These are the ones more likely to get severe disease, the risk factors.
Dr. Suresh, we lost your voice. Dr. Suresh, you may need to repeat, but first of all, we need to get your voice back. Suresh, we can't hear you.
Your line is not stable.
Okay, can you hear me now?
Yes, you can continue. We can hear you now.
We go back a bit.
Yeah.
Please. Go back to your slide on the severe disease.
Okay, fine.
Before this, we lost your voice in previous slide.
Okay.
Yes,
So
right.
this is a severe disease, right? These are risk factors I mentioned earlier. These are the risk factors for severe disease that has been proven by literature. Older age group, pre-existing pulmonary disease, chronic kidney disease, diabetes HbA1c more than 7.6, hypertension, cardiovascular disease, and obesity. And these are the risk factors. When do people get severe disease? We usually think they get anywhere from day 5 to day 10 of disease. That's when severe disease usually happens. What are the warning signs? What predicts that these people are going to get severe disease? These are people who have got a shortness of breath on exertion, those who have got SpO2 that is low, or somebody has got persistent or new onset fever. These are the ones, clinical features that tells us this person is going to deteriorate. Laboratory markers that tells us they're going to deteriorate will be increasing CRP or rising CRP, or CRP that is raised. We don't have data for it. We don't have solid data for it, but our impression is CRP is more than 70 to 100 seems to be a warning sign. Increasing ferritin or a rise ferritin, ferritin more than 500, we think it is a warning sign. Persistently low or dropping lymphocyte count of less than 1, again is a warning sign that they might get severe disease. And radiological criteria will be a multi-lobar involvement or rapidly worsening chest x-rays. These are the features we look for. So in all the cases that we are looking for, we look for risk factors, we look for the duration of disease, how long they've been sick, and then we look out for warning signs. And with regards to risk factors, the most significant risk factor is age. As you can see here, this is again data from our database looking at age group versus severe disease. As you can see here, the younger age group, there's hardly anybody who gets severe disease. On the other hand, if you look at somebody is more than 81 years of age, 63% of them get severe disease. So age by far is the most important risk factor for somebody to get severe disease. Moving on to the phenotypes of severe disease that we see. As I mentioned earlier, everybody has a viral response phase. And then the people who get severe disease, especially one subgroup of them, what I call now as a CRS subgroup, a cytokine release syndrome subgroup, the host inflammatory response kicks in. And obviously it happens anywhere from day 5 to day 10 of disease. And the host inflammatory response kicks in and they get severe disease. So the severe disease is not because the virus is uncontrolled, the severe disease is because of host inflammatory response. So how do we pick up these patients clinically? We pick it up by persistent or new onset fever, increasing oxygen requirement. So all these actually, as you know, we call them warning signs. Increasing CRP, increasing ferritin, low or dropping absolute lymphocyte count, and if it is available, high interleukin-6 levels. So when we have somebody who is becoming more hypoxic, and along with it, we see all these markers, it sort of hints to us that this person is getting a severe disease because of post-inflammatory response. The second subgroup of patients that get severe disease is the ones that have got comorbids. So they have the viral response phase and then their comorbids worsen. So classically, we see that in our end-stage renal failure patients who are dialysis dependent, they might require high-flow mask or even ventilation, but predominantly it is because of the comorbids getting worse, nothing else. So there are some people who deteriorate purely because their comorbids are not controlled. That's the comorbid group. And the last group that gets severe disease is a viral pneumonia group. The viral response is not controlled at all. The host inflammatory response is there, but it's not very prominent. And this group are the people who have persistent or new onset fever and increasing oxygen requirement, but all these markers don't go up. These markers that tells us about inflammatory phase doesn't go up. So this is a group where there is a viral response phase that is predominant, and so depending on the risk profile, the patients could deteriorate because of any of these parameters, right? Okay. So when we look at COVID-19 treatment, so we have three modalities of treatment that I need to discuss about. One is the anti-inflammatory or immunomodulatory therapy. The second is antivirals, and the third is regarding the anticoagulation treatment. I'll just go through it one by one, right? Okay. There's an early study done in Germany that looked at IL-6 levels. IL-6 levels, just 40 patients. 40 patients, 1/3 of them required ventilation. And when
Sorry, Dr. Suresh, we cannot hear you again.
Is it because of the weather?
Dr. Suresh? They didn't look at the CRC. Use handphone transfer again.
Ask them to cut the HD. Webcam don't put HD. High definition.
Yes, we can hear you now.
This is a study that looked at IL-6 levels. And so 40 patients, 1/3 of them required intubation. And if you look at IL-6 levels, when the IL-6 level is less than 80, only 4% required intubation. The IL-6 is more than 80, it was 92% of them required intubation. And the IL-6 started going up about 1.5 days before intubation, sort of telling us whether IL-6 levels predicted people who need to be intubated. And so this sort of very early on told us that, there is an inflammatory response that needs to be tackled when we control COVID, right? There are subsequent studies. This is a study in Italy where they gave IL-6 inhibitor called tocilizumab. When they gave IL-6 inhibitor tocilizumab, what happened? The D-dimer rates came down. The CRP levels came down. The ferritin levels bit more slower and coming down, and the absolute lymphocyte count went up. So all the warning signs I spoke to you about, all those sort of recovered. And if you can see here, the PaO to FiO2 ratio improved, the oxygenation improved, showing us that there is an inflammatory response, especially IL-6 increase, and correcting it makes it better, right? This is moving on to the recovery study in UK that was done in UK, which is just starting to come out as press releases before it comes out as a journal paper. In this particular study, they gave DEXA for as indiscriminately, not like how based on the warning signs I spoke to you about. I told you about the warning signs like CRP going up, ferritin going up. All that was not looked at. Everybody was given dexamethasone 6 milligrams and then compared with placebo. And they looked at 28-day mortality rates. So if you look at the 1,007 of them who are mechanically ventilated, dexamethasone improved the 28-day mortality by about 30%, or 1/3. And if you look at those who are on supplemental oxygen, about 3,000 odd people, almost 4,000 people were in this study arm, it improved the mortality by about 20%. But if the dexamethasone was given for people who were not on supplemental oxygen, there was no improvement in mortality. In fact, maybe you could argue there was some non-significant direction towards harm. So sort of tells us that, if you had to give, so majority, at least a big chunk of the deteriorations in severe dengue is because of inflammatory response.
COVID.
Sorry, dengue. Sorry, it's COVID. Inflammatory, big chunk of the deteriorations in COVID is actually because of inflammatory response, because giving dexamethasone to everybody actually decreases the mortality rate. And then what do our MOH guidelines say with regards to this, right? So right from quite in April, we have said if patients on category 4 and category 5, those who require oxygen, if we need to look out for markers such as a cytokine release syndrome based on these criteria mentioned earlier. So when any of these criteria is present, then our recommendation is to give dexamethasone, methylpred, or tocilizumab. We have used a shorter course of treatment compared to what is recommended in the recovery study. This is our own recommendation. We are still continuing this particular recommendation. But we are not giving to everybody that requires oxygen worsening, but we are looking for markers of high cytokine release before giving it. And that's our data. Right? So that's regarding anti-inflammatory or immunomodulatory therapy. Moving on to antivirals, role of antivirals in treatment. So early on, there's been a study done by the randomized study done by the Chinese group that looked at Kaletra, lopinavir, ritonavir, an HIV drug that was repurposed for COVID. And the final result of the study was lopinavir did not make a difference. But some information came out from that study is that we need to give antivirals early. If you can see this particular graph shows you whether there is no lopinavir given less than 10 days. When you give it lopinavir less than 10 days, it made a difference with regards to number of people who are becoming COVID negative. But if you give overall study, there was no difference. And so looks like for antivirals to work, we need to give it early. Second study is there's a study from Hong Kong. Here they tried 3 drugs: interferon beta, ribavirin, and lopinavir, and the 3 drugs: interferon beta, lopinavir, and ribavirin. Right? Again, some
No more audio. You got disconnected again.
Suresh, sorry, you got disconnected again. Yes, you're back. Yes, I think we can hear some.
okay.
Yes, I can hear you now.
So the Hong Kong study shows that, if you were to use 3 drugs, less than 7 days, best outcome. Compared to the worst outcome will be lopinavir alone given more than 7 days. So looks like if you were to use antivirals as a treatment modality, maybe we need it in combination and also has to be given early. So this particular study says we need to probably give it less than 7 days of disease. And the most recent study is the study that looked at remdesivir. Remdesivir for treatment of COVID-19 done in US, and these are the baseline characteristic of patients. Majority of the patients they gave remdesivir is for hospitalized patients receiving supplemental oxygen. They've also had hospitalized patients not receiving supplemental oxygen, and then there are other groups: non-invasive ventilation, invasive ventilation, and ECMO. So these are 4 groups that they had. So this is the least sick group, there's a subsequent group, and these 2 are the critically ill group. And they had about 1,000 patients, or 500 remdesivir and 500 on placebo. Right? And if you look at the data, the ones that did not require oxygen, the outcome was not different. What they looked at was days to recovery, meaning how many days it took to go back to category 1 and 2, at least 2 category points less. That is days to recover, because the study was published so fast that they couldn't look at mortality data yet. And so if you look at it, the overall study, there was people who took remdesivir became well faster at day 11, while people who took placebo became well slower. It took 15 days. And most of that data was in the severe group, 12 days versus 18 days. The one that did not require oxygen, there was no difference in the two groups. So the question is whether the milder group, we ever need to give antivirals or not is a question that we have to ask ourselves. Okay? And if you look at the mortality, as I told you earlier, the mortality data was not complete. They did not have complete data for the mortality because it was published very early. The overall mortality benefit was 0.7, 30% better mortality rate, but however, it was not statistically significant. Overall, there was no mortality benefit. Either the study was not powered enough for that, or the study was terminated too early, right? But if you can look at the signals, the best signal was for category 5 in patients who required oxygen. In category 6 and category 7, those who required ventilation and or required high flow mask and non-invasive ventilation, it did not seem to make a difference. Maybe antiviral alone is not enough in this group. Maybe what the UK recovery study did, the anti-inflammatory drugs are required in this particular group. The antivirals made a difference in this group and this group as far as mortality benefit is concerned, but none of the data was statistically significant. We are waiting for more data from this particular study. The other drug that I want to talk about is favipiravir, which is available in Malaysia currently, but not available in many of the Western countries. So favipiravir this is a before and after study comparing lopinavir, ritonavir with favipiravir. And they looked at, again, positivity rate, and they're able to show that favipiravir compared to Kaletra was a better antiviral as far as making the nasopharyngeal swabs negative is concerned, and it brought it down faster. And this translated into better CT scan results too. CT scan improvement also was higher in the favipiravir group compared to Kaletra group. The patients in the study arm were very mild cases, and none of them passed away, or none of them were ventilated. So that's why we couldn't look at mortality and school. So favipiravir also seems to be another antiviral that seems to work. The last one I want to talk about is hydroxychloroquine. There are many studies on hydroxychloroquine since. I just want to pull out one study, the French study that looked at hydroxychloroquine once again, because it is the French that confused us in the first place by saying that hydroxychloroquine is a wonder drug and nobody should be without the drug. And so this is actually a retrospective cohort study. They looked at all their patients who were on hydroxychloroquine versus those who were not on hydroxychloroquine, and they tried to balance for all the relevant confounders like age, time since symptom onset, and severity of disease at first presentation. So these are the three important parameters, and they adjusted for that. After adjusting for it, as you can see here, the other thing I want to point out is they gave it for patients who at around 8 days of illness, many of them actually requiring oxygen. SpO2 was 92%. Many of them requiring oxygen. This is a group that they gave hydroxychloroquine, and they found there is no significant difference between the groups, either for transfer to ICU or death within 7 days, all-cause mortality, development of ARDS, all that was not significant. There was some 9.5% of them had QT prolongation that required intervention, discontinuation of drug. So showing that hydroxychloroquine may not make a difference in these particular studies compared to one. So we are looking at our own data currently, and we looked at about 586 patients with stage 2 and stage 3. So we're looking at patients who had mild disease to start with. They did not require oxygen. So 451 of them were initiated hydroxychloroquine. We gave it for 5 days. We compared them with historical cohorts. About 135 patients, historical cohorts without hydroxychloroquine, because at that particular juncture, before the national guideline was put up on hydroxychloroquine, we were using only Kaletra, especially in Sungai per mile in Johor. And so this is what we compared with. And we were all hoping that the hydroxychloroquine arm was prevented deterioration. But when we looked at our data, proportion deteriorate to stage 4 to stage 5. Hydroxychloroquine was 10% and pre-hydroxychloroquine was 8.9%. They were not statistically significant, and so hydroxychloroquine doesn't seem to prevent deterioration to rapid disease. We are looking at this data again and again. We are trying to analyze it, analyzing for confounders some more to see whether we get any different results. But based on all this data and the data from I think from the Solidarity study that is going to come out again, a WHO Solidarity study that's going to come out again saying that hydroxychloroquine is not going to make a difference. I think the hydroxychloroquine era or in Malaysia might stop, and we may not be using hydroxychloroquine to treat COVID for the time being now, right? But of course, the definitive data is going to come out from this study that is done by NIH, that's including 2,000 patients. They're looking at people who are early COVID disease. So if you're hospitalized, you exclude them from the study and see whether hydroxychloroquine started very early will prevent hospitalization. This is including 2,000 patients because that's the kind of data that's the kind of numbers we need to prove this data once and for all. So until this will be the conclusive study that tells us about hydroxychloroquine. So what does our MOH guideline says? For category 4 and category 5, we use lopinavir, ritonavir, or atazanavir, ritonavir, or protease inhibitors, and favipiravir. That's the 2 drugs that we are currently using. But just remember, the favipiravir teratogenic, and so we'll have to be careful in reproductive age group. But if somebody comes less than 7 days of illness, from the data from Hong Kong, we will use beta interferon therapy if they come in less than 7 days. More than 7 days, they will just get only these 2 drugs. These are the drugs that we're using. Again, all the patients that we're starting on these drugs are part of our registry, and we will analyze the data the same way we analyze the data with hydroxychloroquine from time to time and revise our guidelines. I've mentioned this earlier. So we don't know. Category 4, category 5, very clear. So we still don't know for category 3 with risk factors or with warning signs whether we should start treatment. We were used to starting treatment there, but when we looked at the remdesivir study, we have to go back to the drawing board and ask ourselves whether do we need to treat category 3 with risk factors or category 3 with warning signs. Category 4 and 5 are very clear. We will still give antiviral treatment. Moving on to the last part of it is regarding anticoagulation. There is tons of literature out there now that COVID-19 causes hypercoagulability and causes lots of, even in Sungai Buloh, we had 4 to 5 patients who had confirmed pulmonary embolism due to COVID. And so these two arms are clear cut. So the current data says we need to do full dose anticoagulation. Example, if we had to use enoxaparin, we have to use 1 milligram per kilogram 12 hourly. In anybody who's got confirmed venous thromboembolisms, anybody you even suspect pulmonary embolism, maybe they have sudden deterioration in oxygenation, sudden deterioration in hemodynamic sensitivity, or they're getting acute cough pulmonary, the right heart, there is right heart dilatation, then you should start full dose anticoagulation. You should also start full dose anticoagulation if you're starting declotting of the vascular devices. So I'm told by my intensivist, Dr. Lee C.K. saying that, the CRT circuits very often gets clotted in COVID patients more than other critically ill patients. And so all these patients gets a full dose enoxaparin. While on the other side, prophylaxis, 30 to 40 milligrams, for example, if you had to use enoxaparin, 30 to 40 milligrams of enoxaparin, depending on renal function, we give for all patients requiring supplemental oxygen. So category 4, anybody in category 4, we start them on prophylaxis. But the current literature currently saying, data coming out from Europe, saying that these patients, while on prophylaxis, a lot of them are still getting thrombosis. And so this group is something that's being toyed now, but there's not much data, but just by peer opinion, what is called high prophylactic dose anticoagulation, meaning the dose is something like 0.5 milligram
Sorry, conclusion. Suresh, we cannot hear you again. Suresh?
Is it
Hello? Yes, we have to start this slide.
still
Suresh, we cannot hear you. I don't think he can hear us.
Dr. Suresh, there's no audio from your side. Hello.
Hello, Suresh, we cannot hear you. I think it's on. We continue. Suresh, we cannot hear you, and the other media also we can't hear. We have only one audience, then Dr. Chris. We can't hear from last three slides.
And so this
Just to confuse that.
Last two slides.
okay, fine. Okay. So monitoring, what made a difference is it is not that the treatment, it is not the antiviral treatment and steroids and the anticoagulation made a difference. It's also the monitoring guidelines, self-proning and complete rest in bed and drug interactions makes a difference. So we taking a leaf from our dengue way, the way we manage dengue. So we came up with clear guidelines on how often to monitor for warning signs, how often to do blood tests to pick up those warning signs to decide. So if somebody's got category 3, we have to review the patients 3 times to look for these warning signs as well as look for any deterioration. And somebody requiring oxygen as category 4, we have to monitor them 4 hourly. Again, we have to look for, we might have to do all these blood tests to look out for cytokine release syndrome so that we can start anti-inflammatory immunomodulatory therapy early. And last thing is we also very learning from the Chinese group, where patients are starting to having exertional dyspnea, we encourage them to do self-proning, and we also ask them to be, as far as possible, complete rest in bed. And every single drug that we use, we go to this particular website and look for drug interactions, because many of the drugs that we use have got lots of drug interaction, especially in the ICU, because they can all prolong the QT interval. And that's it. Thank you.
Yes, Dr. Suresh, if you can go back to slide 33, we would like you to repeat that slide. Sorry about it. I think you can rewind your brain and go back to slide 33. Okay, go back. One more slide, one more.
Yes.
Yes, this is the one.
Okay. As I mentioned earlier, coagulation is a big problem with hypercoagulability in COVID. There's lots of reports on pulmonary embolisms. Even in Sungai Buloh cohort, we have at least seen 4 or 5 patients who had confirmed PE. And so these 2 arms are very clear cut. We use full dose anticoagulation. Example, if you use enoxaparin, 1 milligram per kilogram 12 hourly for normal renal function. So for anybody who's got confirmed venous thromboembolism, or even if you suspect pulmonary embolism, maybe by suspect because there is sudden unexplained deterioration, oxygenation, hemodynamic instability, acute core pulmonary by right heart dilatation. When you suspect, you should start full dose anticoagulation. I'm told by my ICU colleagues that the CRT circuits become clotted very easily. So when you start seeing clotting of vascular devices, again, you should start full dose anticoagulation. On the other end, we recommend, example, enoxaparin, for example, 30 to 40 milligram daily based on renal function for any patient who requires supplemental oxygen. But data is emerging that patients who are while on prophylaxis, data from Netherlands as well as Europe, other parts of Europe, saying that patients on this prophylaxis still get venous thromboembolisms. And so now there is a recommendation that we should use high prophylactic anti-dose anticoagulation for a selected group of patients. And these patients are, but the problem with the high dose means 0.5 kilogram 12 hourly, but whom to give is controversial because different centers recommend different things. Some recommend for all ICU patients, some say we should base it on D-dimer values. Again, the D-dimer values are different. Some uses 3,000 as a cutoff, some use 5,000 as a cutoff. But we will meet, we will discuss this, and we will come up with a consensus for this particular part. But I think some require high dose anticoagulation.
Right. Pikwin, was it okay? Did you catch everything?
Yes. If not,
Okay,
we can. We hear the missing slide, so we shall wait for the questions.
Right. Okay. Thank you, Suresh. And I think he may have done this all in 40 minutes or so, but I think what he has done, he has squeezed 5 or 6 months of experience around the world into a 40-minute lecture, and he has done it very well. So he has made it very easy for those of us who are not actively seeing patients on a day-to-day basis. He has summarized it very nicely in a very compact form. So thank you, Suresh. Just a quick question. We will deal with the proper Q&A together with both speakers. I noticed that ribavirin, it's not in our MOH guideline now. Is that because of data or because of access?
We initially started using ribavirin, and then we had problems with anemias and platelet issues and liver issues, and so it's a lot more messier drug to use, and other than Hong Kong, nobody else had tried the drug, and so we didn't subsequently follow it up with it.
Right. Okay. Yeah, I think mainly it's issue of our own experience with ribavirin in treating patients with hepatitis, for example. There were issues. Well, okay.
Please, we cannot hear you. So I introduce, I think I will, in the interest of time, I will introduce Faizah Muhamad Zin. Faizah has been a good friend of ours. He has been doing this mortality review from the NIH on the COVID-19 patients chaired by Dr. Chris. He's also the head of clinical audit unit, medical care quality section at the medical development division in the Ministry of Health. And she has not very young, but she has already 16 years experience working. So without further ado, I would like to invite Dr. Faizah to talk about COVID-19 mortality review in Malaysia. Thank you.
Assalamualaikum and very good afternoon, everyone. I'm Faizah from Medical Development Division. So my presentation today is going to be on COVID-19 mortality review. As you can see that we are actually the member of the National COVID-19 Mortality Review Committee established in March 2020. Again, the normal disclaimer, I think you guys can read that. All right, this is the outline of my presentation. So basically, I'm going to start with the background of the committee, and then after that, the overview, proceed with the demographic and also the clinical profile of our mortality review, risk factors, clinical management, and also our findings and recommendation, and also some of the directives that has been actually circulated from our Deputy DGs and DGs office. So a little bit on the background. On the 20th of March, what happened during the National CPRC meeting, which was chaired by our DG, he has decided that we need to form a national committee for COVID-19 mortality review. As we all know that our first death was on the 17th of March, 2020. And then subsequently, the decision to actually form a committee has come upon during the National CPRC meeting. And on the 23rd of March, we had our first discussion with our chairman, Dato.Dr. Chris, our dear Dato.Dr. Chris. And the objective of the committee is actually to review the COVID-19 mortality cases, to look at the systemic issues, and also to identify the areas for improvement in order to make recommendations based on the review in the pursuit of improving patients' outcome, and also to reduce morbidity and mortality among COVID-19 patients. So from the 27th of March until 18th of June 2020, I mean until today, we had some intensive review that we had done, and in total we had engaged with 13 meetings, and you guys got to know that we were a little bit aggressive during the initial phase because of our death was actually keep on increasing during the initial phase of the disease progression. So what we had done is that we had a meeting on every Tuesday and also every Friday. The first two initial meetings were physical meetings, then subsequently followed with teleconferences meeting. How do we do it? We actually collected all the case records, basically BHT, from the respective hospital, and then after that, subsequently, we discuss about the mortality, and also bear in mind that we actually need to look at every pages of the BHT, and we get our committee members to actually review the cases and comment on everything as a committee. So yeah. Okay, so basically this is our committee. As you can see, that's our beloved chairman, Dr. Chris. And then we have a very esteemed lineup. We have Dr. Buloh with us, Dr. Lech, Dr. Shanti, Dr. Asri, Dr. Anusha, Dr. Siti Sohaila, Datuk K, Dr. Kautman, sorry, Dr. Hidayah, Dr. Karil, Dr. Azaini, our forensic team, Dr. Sio, our forensic team, Dr. Fazila from our medical care quality section, Dr. Noraisha, and also Dr. Shaniza from medical development division. And I'm one of the secretariat, and also with my team, clinical audit unit. In January 2020, WHO has defined the death of COVID-19 is actually the death of a person with laboratory confirmation of COVID-19 infection, irrespective of clinical signs and symptoms. Since our first death happened on the 17th March of 2020, hence we followed this definition. And the definition of mortality rate is actually number of deaths with positive COVID-19 laboratory test divided by the number of positive cases at a given period of time. However, after we had followed the definition, and then on the 16th of April, WHO has published this international guideline for certification and coding for COVID-19 as a cause of death. So it was clearly stated that a death due to COVID-19 is defined for surveillance purposes as a death resulting from a clinically compatible illness in a probable or confirmed COVID-19 case, unless there is a clear alternative cause of death that cannot be related to COVID disease, for example, trauma. There should be no period of complete recovery from COVID-19 between illness and also death. A death due to COVID-19 may not be attributed to another disease, for example, cancer, and should be counted independently of pre-existing conditions that are suspected of triggering a severe cause of COVID-19. So luckily for countries which had their first death after 16th of April, they followed this new definition. But for us, we still stick to the old definition. So a little bit overview on our mortality rate. As you can see, this is comparison with our Asian country. And you can see that Malaysians, our mortality rate to date until yesterday is at 1.42%, as compared to Singapore is 0.06%, Thailand is 1.85%, Myanmar 2.29%, and Philippines is 4.07%. Indonesia, yeah, as we all know, their mortality rate is about 5.49%. So we are actually doing quite well. And this is actually, the graph shows our first mortality until yesterday. So as you can see, from the 17th of March, we had reached our peak somewhere around end of March, and then subsequently our first recommendation from the mortality committee actually happened on the 30th of March, and then we had a series of recommendations after that. And after we reached the peak, somewhere around mid of April, then after that we started to have sloping down of the graph, and then our death is plateauing at more or less 0 to 1 per day until yesterday. So at this point of time, our death number is actually at 121, and our positive cases in Malaysia is 8,515. This is actually mortality by state. You do not need to actually conclude that Perlis is actually having the highest mortality. This is simply because the denominator is a bit lower in Perlis as compared to other states. But this is basically the mortality rate for every state. This is actually the number of mortality based on hospital. Again, do not assume that HKL is not doing well. It's nothing to do with that. It's simply because, as we all know, that in Malaysia, what we have done is that we have classified our hospital into COVID hospital, hybrid hospital, and also non-COVID hospital. So HKL happened to be one of the hybrid hospital. Also, Hospital Kuching is one of the COVID hospitals. Sungai Buloh again is a COVID hospital, and also Kluang is a COVID hospital. So, of course, when they actually being referred to all those cases, of course, I mean, common sense, their death is going to be a little bit higher compared to other hospitals. And if we look at the next slide, we look at the cause of death. So, based from the death certificates, about 81% of our cause of death is actually being contributed by pneumonia. And then the moment the patient sets in with pneumonia, they started to have multi-organ failure, ARDS. But having said that, there are few instances, about 9%, about 10% actually, patients die because of acute coronary syndrome, perhaps due to complication of that disease itself, or maybe because of it's the primary disease. As you know, like what Dr. Suresh had mentioned, that most of the patients, they have multiple comorbid hypertension. Some of them is a well-known case of heart diseases, acute coronary diseases. So this is bound to happen. And then there are about 4% died due to malignancy, and isolated cases about 0.8% due to acute pulmonary edema, hanging, severe dehydration, ruptured AAA. Yeah, hanging. Yeah, that's right. Ruptured AAA, and also one unknown case of which we didn't know. Basically, we have no idea. It's not that we have no idea. It says that when the patients come, we really do not have any information on that disease. Okay, then we proceed with the demographic and also clinical profile data. This is roughly based on nationality or mortality. Majority of our death is actually Malaysian, about 96%. Non-Malaysian contributed about 3.3%. Unknown is about 0.83%. This is the gender-specific mortality rate. Hold on, wait a moment. Oh yeah, I can change it here. Easier for me. No, because the video is on this side, so I can't see. But anyway, yeah, can. Now I can. So basically, gender-specific mortality rate. Basically, okay, as what we know, that male is actually more predominant than female in terms of mortality rate, and also in terms of number of positive cases. So for male, for our mortality is about 72%, female is about 27%. But the male mortality rate and also our female mortality rate is almost the same in Malaysia. Male is about 1.43%, female is about 1.4%. Race-specific mortality rate for our mortality is Malay contributed about 1.65%, Chinese about 4.7%, Indian 3.5%, Bumiputera Sarawak is about 1.5%, and Bumiputera Sampai is about 0.5%. Age-specific mortality rate, okay, this is the same throughout the world. And as what Dr. Suresh have mentioned, that the older you are, the more severe disease that you will get. And it's true, if we base on our mortality data, it looks the same actually. If you look at our graph, those who are actually below 50, the mortality rate is only about not even reaching 1%. But if you see that those who are actually above 50, mortality rate 50 to 59 years old, mortality rate is about 1.87%. 60 to 69 years old, mortality rate is about 5.28%. And then if you look at more than 80 years old, contributed about 22% of our data. And then after that, 70 to 79 years old is about 12% of our data. And when we look at the onset of symptom to death, the mean is actually about 16 days. And then if you, majority of them actually died after the onset of symptom more than 9 days. So it's about 87%. And if you look at symptoms, onset of symptom to admission, majority of our patients actually presented to us. The mean is about 7 days, and majority of them came after a week. So it's quite a late presentation, like what Dr. Suresh mentioned just now. The best time to catch up is actually when the onset of symptom is actually less than 5 days. So if you look at our data, most of them is actually came after 7 days after a week. So admission to death, somehow when we manage our patient, majority of them manage to survive more than 9 days. So about 50% of them actually stayed in our hospital more than 9 days. So the mean is actually about 10 days, and the more than 50% is more than 9 days. So the stage at the presentation, I mean during admission, majority of our cases came late. About 21% came at the stage of 3, and then after that 57% came at stage 4, and then about 14% came at stage 5. So as we know that Dr. Suresh have mentioned just now about when we talk about stage 3, it's actually still mild, but it can progress to stage 4 quite easily, as we know that the disease progression is very, very fast. Patient can deteriorate very, very fast. So when patient presented to us at stage 3, so usually that is the time that we need to alert our anesthetist and also our team to be more vigilant in terms of managing these patients. Presenting symptom, the most common presenting symptom is actually shortness of breath, but this is not surprising simply because when they come at the stage of at stage 3, stage 4, and also stage 5, they were already very symptomatic, and at the same time they required supplemental oxygen, followed by fever, cough, diarrhea and vomiting, and also myalgia, then sore throat, and 2 of our mortality cases, they presented with anosmia. Where do they come from? Majority of our mortality cases came from government hospital, referred from government hospital, and then followed by walk-in into our ED. Then after that, referred from our clinic kesihatan, followed by referred from private hospital, and then some from PKD, some from GP, some from the quarantine center. So we move on to the risk factor. So as you can see, why the slide is not moving? Oh yeah. I have moved my slides.
Exit and present. Exit and then.
Okay.
Exit. Stop sharing. And share new screen.
Yes, there's some technical problem in the slides.
But my voice is okay.
And we can hear you, so maybe you can continue talking about your hospital referral, and yes, this is the
Oh yeah. Okay. Yeah. Okay. Okay. So do I have to repeat this again?
I think you can see
Dato?
from the
Yeah.
slides. Okay.
No need, yeah? Okay. Right. Okay. So, okay. Then. We go to the risk factor. It's the same like what Dr. Suresh has presented just now. Majority of our patients, our case actually with underlying hypertension, diabetes, followed by diabetes and then coronary artery disease, dyslipidemia, chronic kidney disease, obesity, heart failure, malignancy, and then followed by chronic liver disease. And one of the disease is actually had underlying HIV. When we talk about others, it's basically immunocompromised state, of which they have some psoriasis, they have hyperthyroidism. So it's multiple comorbids actually. And if we look at this data, basically we can see that about 70% of our disease have multiple comorbids, more than one comorbidities, about 70%. And single comorbidity contributed about 22%. No comorbidity contributed about 8.5%. But when we talk about those disease with no comorbidity, what happened was they actually usually presented late. So because perhaps they are very, very well, so they thought it's just a normal URTI symptom, so they presented quite late to us. Based from our data, those from the disease, non-smoker contributed about 79.52% and smokers contributed about 20.48%. So in terms of clinical management, I'm just going to go through roughly about this. We have about 63% of the disease is actually being managed, were actually being managed in ICU. Somehow about 21% being managed outside the ICU. But bear in mind, during the initial stage, COVID-19 is a new disease. So basically we were actually quite struggling with our facilities, and not just our facilities, but also in terms of managing the patient. So we thought that perhaps when we intubate the patient in the negative pressure room, in the ward, it was suffice enough. But to be, I mean, when the disease progression, when we know how to manage our COVID-19 better, we know that actually the patient needs to be intubated and ventilated in ICU. So happened to be about 13 of them. From that, 21% is actually being ventilated and intubated in the ward, but in the negative pressure room. And then about 4 of them was brought in PID, and then 4 of them was DNR. Okay. So number of cases treated with hydrochloroquine, majority received the hydrochloroquine, about 80%. Only about 20% did not receive hydrochloroquine. Number of cases treated with antiviral and also antibiotic, about 90% received both. Only about 10% did not receive any antiviral or antibiotic. But as you can see, the aid is actually being, the fraction of the aid is actually coming from the BID and also from the DNR cases. Okay. So after we have reviewed majority of the cases, so basically we have 121 cases, and we managed to actually look into around 70 BHT to date. And based from that 70 BHT, more or less, majority of the issues are actually recurring issues, and it happened during the initial phase of the disease. So based on that, what we have found is that most of the patient, majority of the patient, you guys are losing me? Okay, can. Okay, so majority of the patients may look very comfortable. So like what Dr. Suresh have mentioned, that you really need to assess the general appearance of the patient together with the clinical examination and also the laboratory parameters. Not only that, together with the radiological findings. Most of the patient is in hypercoagulable state, so DVT prophylaxis must be started early. Prompt anticipation of COVID-19 patient deterioration status. So basically, the patient require close monitoring, and when we see the patients come stage 3, and after that need some NS referral, need intubation, so the patient needs to be ventilated in ICU. Not only that, we also look into some other things rather than only clinical management. But when we talk about some other things, we're talking about communication between the managing team, between the emergency physician, between the physician, the infectious disease physician, also with the anaesthetist and also the intensivist. This is actually to prevent any delay in treatment and management. Some logistic arrangement for ICU care between COVID and non-COVID hospital also needs to be strengthened. And all this has been done after our first recommendation. So it's not that we are saying because of the delay or patient died. You cannot pinpoint one single factor why the patient died, but we have to bear in mind that this logistic arrangement do occur. Logistic problem do occur at the initial phase of the disease. So this is one of the things that we have looked into. And also early referral to the critical care team, especially for elderly, for the high-risk patients, elderly, pregnancy, obese, or any COVID-19 patient with comorbidity, regardless of stage at presentation. Okay. So when we talk about our recommendation, what we are looking into is actually we are looking to improve the outcome to reduce morbidity and also mortality. And at the same time, we are looking at the post MCO and also future pandemic preparedness. So because of that, we are looking into three things, of which we are looking into. We are looking at the structure, the process, and also the outcome of what we are doing on the ground and also at the administrative level. So, but the foundation of all this is that the hospital administrator must be involved in the management of COVID, especially in the mortality review discussion, because as we all know that it's not all about the clinical management, it's also about the administrative of the hospital in terms of we providing the best quality care for our patients. And also at the same time, we need to enhance multidisciplinary communication in managing COVID-19 cases, and also the teamwork must be there in order for us to actually achieve all this. So in terms of structure, basically we have proposed that patients should be managed in ICU. The hospital must prepare a mortality report, and also systemic referral and patient transfer from one center to another must be there. For our preparedness, future preparedness, post-MCO, and also another pandemic preparedness. I hope not, but we never know. So in terms of structure, our intensive care unit shall be equipped with negative pressure room, proper logistic and resources management in terms of transferring COVID-19 patients, proper laboratory setup, and also the planning of the capacity building of the subspecialty training, especially for intensivists and infectious disease physician. When we talk about process, we must remember that need to comply with the usage of whatever, the admission sheet that we have come out, monitoring sheet that we have come out, and also the guideline of COVID-19 management. All this we have come up with the help with collaboration with our ID physician, with our hospital administrator. So the compliance to all these policies that we have put in line is actually a must. And early referral to the critical care team. For the post-MCO and future pandemic preparedness in terms of process, we must remember that continuity of care of COVID-19 patients is very important, especially when we talk about the from the COVID hospital to non-COVID hospital. So the continuity of care must be there. Adherence to the utilization of PPE and also guideline, and also we might need to consider to use mechanical CPR device for infectious disease patient. And in terms of outcome, clinical documentation needs to be improved. Basically, no more chartology, especially on the respiratory rate, the examination finding, especially on exertional dyspnea, on the SpO2 monitoring, DVT prophylaxis, and also standardized blood investigation that may indicate patient status, like what Dr. Suresh mentioned, CRP, and also serum ferritin. And then in terms of future preparedness, we need to develop a guideline for DVT prophylaxis. I believe that this is work in progress with the intensivists, and then revision of SOP and guidelines from time to time. It's a new disease, so it's still evolving in terms of management, and hence our SOP and also our guideline must be revised from time to time. We also need to focus on research and publication. We do have a lot of data, but yet, you guys know what I'm talking about. So we must focus on research and publication. And then after that, continuous education and also continuous awareness on COVID-19. And we should use postmortem as a tool to understand the clinical cause of disease, of which we usually, sometimes we take it for granted, I must say. So that is the reason why our postmortem team, our forensic team is actually on board with us in the committee. I'm sure Datuk Chris is agree with this. Okay, so I'm going to share you with some of our directives. So basically, we had our first meeting on the 28th of March. So on the 30th of March, we came up with our first admission sheet, and this is together with our ID physician, it has been circulated on the 30th of March. And then after that, on the 12th of April, we come up with our infographic recommendation, enhance quality care, improve patient outcome in hospital setting for COVID-19 patients. So we were talking about the admissions, what to do during admission, what to see during admissions, what do you need to identify during admissions, and then after that, during inpatients time, what do you need to monitor, what do you need to actually really look into when the patient is actually in the ward, and then after that, the discharge plan, what are the criteria for discharge plan, the discharge criteria from the ward. And then continuous surveillance letter, a lot of letters coming out from the Deputy GT office. I think everyone knows this, but the two most common, not most common, what I mean is that the most aggressive letter is actually coming from Deputy DG when he talks about the continuous surveillance of patients, COVID-19 patients management. So if you look into the letter, the content is actually more or less the same, but we really have to do it very aggressively, because at that point of time, we really think that there's no other way to do it rather than being very aggressive in terms of our directive. And we also have come up with reclassification of the cause of death based on the new guideline that came out on the 16th of April. So we need to reclassify our death. It's not that we want to actually amend the number of death, but we really need to be clear of our death, whether the patient died because of COVID, died of COVID or died with COVID. So this is the reason why this letter came out. And then at the same time, we actually have circulated another letter for the hospital to do their own mortality review at hospital level for COVID-19 death. So in summary, our committee hopes that our recommendation made will be taken into consideration, of which majority of our recommendation has been taken into consideration. And this is actually to ensure the best outcome and the highest quality of care being delivered to our patients. And the recommendation must be carried out in synchronization with the clinical team in the management of COVID-19 patients. And the findings and data that has been generated should be combined with our clinical data to ensure the overall improvement can be carried out systematically. As a committee, with the collaboration with NIH, with CRC actually, with Datuk Grove's team, we are coming out with our paper, our very first paper on mortality review, perhaps somewhere next week. And perhaps somewhere next week. So tunggu.
Yes.
Yeah. So with that, I thank you.
Thank you very much, Faizah. I think I pass the mic back to Chris to do the Q&A session.
Call her.
Okay.
Okay, Faizah, thank you very much, Faizah. I don't know what you did to yourself, but you look younger, so it must be good. Post-COVID. Okay, let's go straight to the questions because time is running out. And let's start off with first question to Suresh. Could you talk about drug therapy in COVID, namely about the withdrawn paper on hydroxychloroquine and also on dexamethasone, which initially people, including WHO, was telling us not to use steroids up front. Now, of course, having said that, it's not wrong. We are not using steroids up front. But I think Suresh may have addressed this, but maybe Suresh, you would like to summarize these thoughts?
The hydroxychloroquine paper, obviously, the concern, we agree with it that it doesn't seem to be useful for COVID, but we disagree with it, saying that it was caused so much mortality. We don't think that happened because we were monitoring our cases, because we were looking at the ECGs and all that. But anyway, you all know now that it was based on faulty data set and which data set overcalled the arrhythmias, and there were never that much arrhythmias in hydroxychloroquine arm. Neither is our response. We didn't see that much arrhythmias, that much cardiac deaths. We will be publishing those data, but we never saw that much cardiac deaths due to hydroxychloroquine. With regards to steroids, just to be fair, WHO and others said there is no evidence for steroids yet, number one, and number two, which is right. And number two, they also mentioned that in SARS, it did harm. In influenza, it did harm. And that's the reason they're not keen. But earlier on, we had seen our own experience after hearing from the Chinese and then from the Italians. We started using steroids end of March for the selected group of patients with CRS. And we have been using it since end of March as a standard of care on our side.
Right. Thank you, Suresh. I think just in relation to what Suresh has said, I think COVID-19 also tells us how careful we must be in sending out papers for publication. I think our robustness in reviewing research papers cannot be let down. And here, because of the need to get data out fast, I think many publications, many journals let loose on that particular area, became more lax with that area. And I think hydroxychloroquine, now we look back at it, we will say, how did we get to our position of making it the norm for all cases? And I think that is a good example for us not to follow again. Now, the next question, let's talk to Suresh, but here, to be fair, I'm not sure whether he's looking after babies anymore, but okay, about Kawasaki-like illness among pediatrics. Perhaps you have some feedback from our pediatrics.
We have not seen one so far, but I think it's a rare manifestation. And lucky for us, we didn't have that many patients infected in that age group in the country. And so we have not seen one so far. And I'm not surprised because it is a very rare manifestation.
Right. As Suresh mentioned, I think our number of cases of peds were actually very small compared to the adults. So we probably won't be the country where you want to look for such cases, right? But it's good to be aware, certainly. I'm going to ask a question to Faizah. We know that in the later parts of our National Mortality Committee, we brought in our forensic colleagues to help us in the committee. Can you share with us, clearly we are not doing post-mortem for every case going forward. Let's hope there are not many more cases to come in terms of mortality. But going forward, what is our game plan for Ministry of Health in terms of when do we do post-mortems among COVID-19 cases who may pass away in the future? Faizah?
Okay, thank you, Dr. Chris, for the question. So, based on our last discussion with our forensic team and also at the National CPRC, we will proceed with postmortem for the unknown death and also for BID cases. So, not everyone we will consider to do postmortem, and perhaps for those patients who death at a very young age, so we might consider that to proceed with our postmortem. So that was the plan, the last plan that we have discussed.
I think there's a question on COVID-19 strain in Southeast Asia. I'm sorry, I'm not well versed with the different strains that is infecting the different parts of the world currently.
Okay. Yeah, not something we are looking at the moment, to be frank. At least maybe only among IMR, only within IMR. The next question is, are there any COVID-19 cases in Malaysia or abroad that affects patients with hemoglobinopathies such as thalassemia or sickle cell? I'm not sure.
Offhand, I can't remember of a case that had thalassemia. Sickle cell disease, of course, it's very rare in Malaysia. Offhand, I can't think of a thalassemia patient with COVID-19, but I'm going to miss one of them. Yeah. What is the next question? What is the panelist's view on using hexaquid early stage of COVID-19 that reduce severity of disease? This is what we were hoping, right? We were hoping that when we start hydroxychloroquine in the early stage, it'll prevent severe disease. The preliminary data on our data set, which is unfortunately is a before and after study with historical cohorts, tells us that it did not do so. It did not prevent, did not reduce the severity of COVID-19 patients, number one. Number two, of course, our study is not powered enough. It can only pick up to an 18% difference. Anything less than an 18% difference, we can't pick it up. The more definitive study is the NIH study that's going to be published soon. And so currently there is no data to say that it does that. It reduces severity of COVID-19 patients.
Right. Okay. Thank you, Suresh. The next question is maybe a topic that you have covered just now, but a question is on hydroxychloroquine. Perhaps they missed that slide you talked about. What is the role of hydroxychloroquine?
Yeah, correct. I saw a question just now. Yeah. So other question was like regarding WHO withdrawing the recruitment. I think we had some discussions yesterday, and I think the WHO's preliminary data also shows that the hydroxychloroquine compared to placebo, there was no advantage of hydroxychloroquine over placebo, and I think they are also in the process of withdrawing that arm from future studies.
Faizah, now we hope we don't get a second surge, but as DG has mentioned many times, we are preparing for that possibility. So in terms of the clinical setup that we have going forward, is there going to be a change in the way we set up our clinical services for COVID-19? As you know, there are some COVID-19 hospitals, Sungai Buloh being one of them, but we also have other hospitals who are a bit of a hybrid platform. But going forward, will there be a change in the way we deal with COVID-19 in terms of our care delivery?
To be honest, we at the Medical Development Division, we have already prepared a few guidelines and also few SOPs of which how we are supposed to see our patient and how we're supposed to operate on daily basis based on the needs of us to actually protect our healthcare worker and also to protect our patients. Basically, we need to actually break the change of COVID-19 transmission. So everything is actually, I can say that everything is in place before Dr. Haizat retires. So, and we have passed out all the guidelines and also the SOPs and all the policies to the hospital. And at this point of time, whatever that we are doing from the COVID hospital to the hybrid hospital to the non-COVID hospital, the transition has been quite smooth, I must say, although I couldn't deny there must be some hiccups at the ground, but at the same time, we are trying to do our best in order to actually to facilitate our hospital. So under the medical program, we are actually looking very, very hard into it and very, very detailed into it, and everything is actually in place. This is actually to the best interest of protecting our healthcare worker and also our patients. So there are a lot of changes in terms of how we deliver our care, not just about the, we try to actually promote video teleconferencing, video telehealth consultation. Not just that, we actually ensure that our hospital practice the 3W, practice the 3Cs. So I would say that everything is in place, Dr. Chris.
Just a quick question to Suresh. He mentioned about steroids, and we are all actually happy to see the data on recovery for DEXA because it's a drug that we can get easy access to. But obviously, tocilizumab also has good data coming forward. Are you aware of any studies that compare these two head-to-head? Are you aware of that?
I think some of the centers, I think Sungai Buloh, Seremban and the actually we have a study currently going on that is comparing metalpred versus tocilizumab. And we are starting in patients who got category 4 disease. And our aim is to, outcome that we're looking for is whether it will prevent intubation. We have the study is ready to roll, but luckily for us, we don't have any patients to enter the study, but that's something that we want to study currently.
Okay, I hate to be a wet blanket. I hope you never have to do that study, even though we need it. Because we certainly don't want many Malaysians getting stage 4 or 5. But yeah, we get your point. Sometimes the timing. So in a way, but I'm sure all of us agree, let's hope we don't have so many cases.
Yeah, I proceed. Maybe we ask Faizah the last question. What is the total number of deaths among frontliner?
Dato Chris, there's no voice from Hospital Sungai Buloh again.
Okay.
Okay, welcome back.
All right.
Question, long-term steroids.
Okay, that's question.
There's a question here. Are patients on disease-modifying agents and long-term or less aggregate CRS? We don't know yet. We don't have enough patients in these groups for us to tell you whether they can. Frankly, I've not seen a single patient on disease-modifying agents who got COVID so far. Maybe they're very careful in not making sure they are maintaining social distancing, and so we don't know that yet. Total mortality, my friendliness, if I'm not mistaken, I just want to point out to you regarding frontliners and COVID, right? So our data says 52% of the frontliners got COVID because of from a healthcare worker to healthcare worker. About 21% got COVID because they got it from the community. Only 18% of them got it from another patient, right? So it's a very small group of people who got it from other group. The second data I want to point out to you is we did antibody study for about 400 frontline healthcare workers who are managing COVID in both HKL and Sungai Buloh, but we didn't find a single one who had antibodies. That's the second amount of data I want to point out to you, right? I think there were 2 frontliners who passed away due to COVID, if I remember right. There's one in Perlis, another one in Johor. That's the data. Are we going to use convalescent plasma in Malaysia? We have convalescent plasma available. We have already collected it and we have kept it ready. And of course, with so much data and so many other drugs available, we have not used one yet, but we have it if it needs to be used. I'll answer the last one and then I'll ask Faizah to answer the pitfalls that we picked up. Unfortunately, I don't have the data on sequencing of the viral strains and mutations. Maybe we should ask NIH whether they will consider another update on these issues from IMR on a later date.
Yeah, we did hear from IMR that they have been doing this. And of course, when we do a lot, you might find some change in the sequence, which doesn't mean it's a sustained mutation. But I think it's a good idea. Maybe Dr. Goh can pass a message to the IMR folks. Maybe perhaps find the right time to talk about this as well. Now, Faizah, I know you gave a short summary just now, but if you could summarize very quickly, what are the common pitfalls that we picked up from the mortality review? I think especially during the first few sessions that we have.
The common pitfalls that we pick up from our mortality review, of course, the monitoring part. But this is all happened during the initial phase of the disease. So basically, we are talking about somewhere in March and early April. Because subsequently after that, it seems that everything seems to be in place. So as you can see from our graph, everything has slowed down and become plateauing. So it actually reflects a lot on the aggressiveness of our management on the ground. So, but the common pitfall is actually, again, is our monitoring at the initial phase and also the awareness to our people that they need to come early. Basically, the suspicious of the disease on the ground. So as we progress, as we go along from March to April to May, then even our community is more aware about the disease. Then subsequently we can detect the disease at the early stage, and then early admission, early stage of presentation. So that, I guess that's the reason why that we are actually doing quite well at this point of time.
Right. Thank you, Faizah. All right. Now, we're going to wrap up soon, but if there are any questions, feel free to send in.
Dato, can I add a little bit more information? So basically, the death among our healthcare worker, our frontliners, there are two deaths. One is actually in Johor, and another one is in Perlis. But both, they did not contract the illness from our patient or from they contracted the disease basically from the community. So it's not coming from our routine work. So I have to make clear of that. Yeah.
Okay. I think having said that, as what Suresh has said, I think despite the initial problems with PPEs and things like that, generally the guidelines are robust enough in terms of addressing infection control issues with COVID-19. And I think we should be comfortable with that. And now that as we are prepared for the second surge, perhaps I think we can probably deal with it even better going forward. Yeah.
Yes.
So I think we are pretty okay in that area. The most important thing is whether our compliance, our adherence to it, whether our folks who are treating patients are adequately trained and motivated to do that. All right, we know it works. I think that's clear enough.
Is the sustainability part actually, Dato Chris?
Correct. And I think the fear for many of us is as our numbers drop, and it happens in all types of outbreaks, just like dengue, as the numbers drop, all of us get a bit complacent. All of us think that maybe I don't have to wash my hands so much, I don't have to wear this or wear that, nothing happens anyway. I hope nobody becomes the first case because of that. So I think for the leaders on the ground, the heads of services on the ground, they must make sure they maintain how important this is. It is still a very deadly disease. I think look at the world figures, it is still more than 400,000 people have died from this disease around the world. It's no joke, it's no joke. Now, one last question here. Suresh, maybe, could you comment on the false positive on PCR testing? I heard him snigger when he saw that question, so let him snigger some more. Okay.
In false positive PCRs, so we do have patients. It's tricky to say what is false positive because, as you remember, COVID diagnosis requires a PCR. The gold standard is PCR positive. So when a PCR is positive, but the patient, and the patient doesn't have any symptoms, which is okay because many people are asymptomatic. If the PCR is positive, they're asymptomatic, and in addition, nobody else seems to get the disease, then the question now is whether it is false positive or not comes up, right? So the possibilities are, we are picking up these people towards the tail end of their disease at day 13 or day 14 of the disease. That time, the PCR can be as low values. That could be one possibility. The second possibility I want to point out is this, it's a statistical stuff, right? So whenever you have a disease that is very rare, when a disease becomes rare, slowly what will happen will be even though the sensitivity and specificity of the test is very good, the positive predictive value of the test starts dropping. So the chance of you coming out the false positive is high. And so as we start getting our disease incidence in the country is lower and lower and lower, the positive predictive value of any diagnostics test will drop. And that's something that we cannot run away from. And so obviously, we need to put clinical and epidemiological data all together to determine the value of any test result.
Yeah, the question here was about false positives. And as Suresh mentioned, it's a very sensitive test if the sample was taken adequately. So false positive probably doesn't happen that often unless there's a significant contamination at the lab level. But the SOPs are really out there, so I think that probably doesn't happen very often. False negative is a whole different ballgame, depending when you take the test, depending how the specimen was taken, etc. And as Suresh mentioned, especially when our numbers in the community drops, how sensitive the test is also will be impacted upon. So it will change. The question is this: if the patient has high risk, if the patient has symptoms to are consistent with COVID-19, if you get a negative test, please do it again. That's a given. That has to be the case. Now, I'm going to summarize now because time is running short. I think we have. I have to give our second apparently.
Doesn't matter. Doesn't matter.
You
Camera.
can
Okay, is it okay, Mohan? Okay, sorry. Technical issues here again. I'm going to wrap up, and I just want to thank the two speakers, both Suresh and Faizah, for their excellent and clear presentation. Clearly, it tells us how far we have gone. 5 months ago, we were preparing for a pandemic that is a true pandemic. H1N1 was a false pandemic, if you can argue the case. But this is for real, because we saw the mortality and it was shocking, and we know how fast it spread. But quickly, we know in the last 5 months, we have found a way to deal with it. In terms of prevention, we know what works. We know social distancing works. We know that hygiene, especially hand hygiene, surface disinfection at the right times work. And I believe strongly that masking works, especially in a confined space where you cannot social distance. We know that works, and we are pretty solid with that. We also know in terms of treatment, there's been also significant progress. Even hydroxychloroquine now, that we understand that it may not work so well, to me is progress. We are not using it as much now, and as Suresh mentioned in the guidelines for Ministry of Health, we have sort of dropped it in the initial recommendation for treatment for COVID-19. But over the last 4 or 5 months, we have now good data on remdesivir, a drug that we do not have free access yet in this country, but I guess it will come, maybe take a bit longer. But we are not completely helpless. We do have the antivirals that we have repurposed, for example, Kaletra or lopinavir that we can use for that. We have the interferon, and of course, we have favipiravir, which actually is an anti-influenza drug. So there's something we can do. We now understand the way to use the immune modulators, and dexamethasone is not expensive. So I think that's an important message to say that when patients get admitted, it's not just for isolation. There's something we can do for them, and I think that's important. One thing that I think Suresh alluded to, and also something we saw clearly in our mortality reviews, that many patients, especially during the early part of the outbreak in Malaysia, many of them came in very late. And I think the moment they came in, they were in 4, they were in stage 5, and the doctors on the ground were struggling with it. So I think this is an important message that we as healthcare providers and other stakeholders must share with our population. If you have symptoms, you need to come forward early enough. And we hope that the testing platform will be fast enough and broad enough, wide enough that we can pick cases up early and we can get onto the management earlier. Because now we can safely say there are some treatments that we know can work. And I think that's an important message. So with that, I would like to wrap up today's session. Again, thank you, Suresh. Thank you, Faizah, for your excellent presentation. Thank you, Dr. Go, as usual, for standing in for me and also making sure all of us behave ourselves. Except for the internet access in Sungai, Buloh, maybe you can donate something again. He likes to donate things to us. So with that, I'd like to thank everyone who has joined in today. I hope you have a great coming weekend. And if it's not too late, to wish you Selamat Hari Raya. So with that, thank you from ICR and NIH. Thank you very much, everyone.
Thank you. Bye-bye. Thank you.